Thanks, everyone. I hope I'm audible to everybody. Thanks to Manjusha and the whole team, and also the moderators here for allowing me to present a little bit of storyline along the membranous nephropathy and the journey. We talked a lot and heard a lot this morning and through the day about patients in hundreds of thousands with different syndromes. And when it comes to rare diseases, we basically slash the numbers down by 1,000 or by 10,000. So instead of talking about 100,000 and 300,000 patients, we come to 100 patients or 300 patients case series. So it's a huge leap. And I suspect at some point or the other, all of us here in this room and outside involved with renal medicine would have felt a deep attachment to glomerular diseases. But it's along the path, as we travel through our careers, we move on to the sidelines because there have not been many breakthroughs. And here comes one disease which I think could help to be a heralding disorder. The path and the journey that it has taken can be used for other diseases in terms of discoveries. So I thought I would talk about the journey of PLA2R amongst these with this outline, but I would ask the moderators to please let me know when you think I should stop and I'll move to the conclusions. So I gave a similar talk back about 5-6 years ago. I think this was in 2015 now, so about 8 years ago, 9 years. And at the time, when you search for PLA2R membranous nephropathy, we had like 60-odd reports on PubMed. And move on to 2 days ago, and we now have 626 reports on PLA2R related to membranous nephropathy. So there is an exponential growth in the last 10 years, especially after the discovery. I think most of us know, just to go through the background, the morphological triad, as we would call it, for membranous nephropathy diagnosis. The first and foremost is a thickened glomerular-based membrane. Then there are the immunoglobulins after the immunofluorescence microscopy along with C3 deposition, and of course spikes on the silver, which are beautiful to see but don't project on screens very well. And lastly, the subepithelial deposits on the electron microscopy. So over a period of, and I mean this story goes back, ends at 1959. So from 1946 to 1959, people knew how to describe MN. And that's it. There's a huge lacuna for just about 50 years until 2009. And of course, most of us would have heard about this story called Hayman's nephritis, which was published in 1959 by the group led by Hayman. Again, this is an artificial or a disease induced in the rats, where Freund's adjuvant along with some rat suspension, when it was given into intraperitoneally, it leads to a severe nephrotic syndrome. Of course, the baseline Freund's adjuvant or some other suspensions like liver suspension can cause some proteinuric disease, but more importantly, the rat kidney suspension. And it took nearly 20 years from there on to understand where the antibodies were and what the antibody was directed against. And we may have heard of Magellan, which is present only in the rats. It's a 330 kilodalton molecule in a glycoprotein present in both the tubular-based membranes, but of course in MN, in the rats, it is present in the glomerular subepithelial deposits. And this was the original report of the normal light microscopy on the left side in the rats, and on the right side is the rats affected with Hayman's nephritis. There's been this speculation, what could have caused the MN in humans? Is it the immune complexes are circulating in the circulation? Or is there a podocyte antigen against which there is antibodies directed against and then get planted? Or is it that actually it's not a podocyte antigen, but it's an antigen which is deposited in the kidney and thereafter an antibody goes there? So there are three different potential mechanisms of injury in the glomerular inflammatory conditions. Any of these could be possible. And there's a lot of speculation, and it took, as I said, about 20-30 years to unravel and to come to William Cose's findings in 1980s to conclude that it is actually a podocyte antigen. So we move on to 20 years, 30 years from the original Hayman's nephritis model, and then it takes another 30 years for us to come to the PLA2R. But just to lay the background on end-stage kidney disease in PMN, why is primary membranous nephropathy important? We all as nephrologists and as patients want to avoid nephrotic syndrome, but more importantly, nephrotic syndrome is the early manifestation, but we want to prevent end-stage kidney disease. This is where I think we could use the model in terms of the development of MN, the journey of MN, to potentially mimic other disorders to, may I say, that we could possibly consider this as a curable disease and hardly see end-stage kidney disease. Maybe not in 10 years, maybe in 10, 20 years' time, we'll say. So going back to the 1980s and 1990s, natural history studies show that if you don't treat patients with MN, 100 consecutive patients from the New England Journal, Schiaparelli's the Italian group, there is a 30% end-stage kidney failure at 7 years. So 70% kidney survival at 7 years. Unselected, every patient that comes through. But you divide that, once you treat them, if you treat them with the Ponticelli regimen, with the original Ponticelli regimen in the form of alternating months of cyclophosphamide and steroids, the 10-year renal survival is about 92%, compared to that at 7 years, 70% kidney survival for untreated patients. So that more or less mirrors. And of course, there are different stratifications that we could use as to predict who is likely to go into end-stage kidney failure. Those with heavy proteinuria, for example, more than 8 grams per day in this paper from Donadio's group, show 50% plus end-stage kidney failure at 7 to 8 years' time. And those, if you don't achieve remission, again, that remains the case, 50% at 7 years. So 30 to 50% is what we could see if either you don't treat any patient with MN, or if the patient doesn't respond to treatment. Now, this is some from our group, which is now probably 8 or 9 years ago that we published this. The 3 graphs at the top is for kidney survival, and the bottom one is for patient survival. So if you focus on just the kidney survival, the top line is all responders. The dark line is the one who have persistent active disease. At 10 years, if they have persistent active disease, you have about only 30% of intact kidney function. So 70% kidney failure at 10 years. So huge burden when it comes to end-stage kidney disease if the patient don't respond. And then, as I said, we know about this now coming to 15 years now. This June, I think it was published the 9th of June 2009, the phospholipase A2 receptor antibody, or PLA2, however you call it. It's basically an antigen which is identified in the podocyte, which is normally present in the podocyte cell membrane, but in MN there is a lot more expression, and there are antibodies directed against them which get deposited. And this is considered to be, in the early studies, of course, at least in 2009, it was considered to be very sensitive and specific. Now, sensitivity varies as you move from the far west to the far east, anywhere between 50 and 80% sensitivity, depending on the ethnicity of the population that you look at. Now, what is a PLA2R? R is a receptor. This is a receptor for a molecule called phospholipase A2, which is present in soluble form in the blood as well. And there is some suggestion to say, some early findings to suggest that actually there may be some tolerance, changes in the tolerance, which actually expose the dominant epitope to the antibody attacks or antibody connections. So PLA2R itself is a glycoprotein, as I said. It's a transmembrane glycoprotein present on the podocyte membrane. It has a cysteine-rich domain at the top, as you could see in the cartoon, and then there are 8 CTLDs, which are the lectin domains, C-type lectin domains, and the dominant epitope is in the C-type lectin domains. Predominantly, it's the CTLD1, and the epitope spreading, as it's called, moves on as time passes to CTLD7s and 8s especially. So it is a conformational molecule wherein it is in a folded form, and there are disulfide bonds which keep it folded, but when there is disease manifestation, the epitopes are exposed so that the antibodies get to bind them. And that is one of the reasons why it took so long to understand this, despite people appreciating that this is an antibody present or antigen present in the podocyte, is because a lot of bench studies were done in reducing conditions where actually they don't keep them intact, the disulfide bonds. And then it's a classical autoimmune kidney disease. So you have the antigen binding to the autoreactive B cell that stimulates the activated B, changes the B cell into the activated B cell, and thereafter the antigen presenting cell feeds onto it, co-stimulation, as in many other immune diseases. What's possibly important and interesting to understand is at various stages of these antigen-antibody interactions and antibody development, there are molecules now which are available that can target individual cells or individual areas. And we'll come to them if time allows. There is this interesting concept. One of my professors called Professor Brenchley in Manchester, he had this idea or an introspection sometimes that it is the lung which is a primary insult in MN. The MN is, PLA2R is present in 3 parts of the body. One is the podocytes, second one is the alveolar cells, and the third one is a few white cells. That's it. It's not present in normal conditions elsewhere. So there is a suggestion or suspicion that it may be an insult or an exposure to an environmental antigen which leads into the PLA2R expression and then the antibody production. It's an interesting hypothesis which is, I think, yet to be confirmed. You may have come across some Chinese studies, for example, linking MN incidence or rise in incidence of MN to pollution, for example. So these may be an underpinning sort of markers or hints towards suggesting that it could be related to exposure of the PLA2R from the lung itself. As I said, I'd probably break the discussion down or the talk down into a few aspects. One is the sensitivity and specificity. Now we know that PLA2R is available as testing for antibody is available as a simple kit. It's a Euroimmune patented kit, so nobody outside the Euroimmune company guys can do it in-house. We used to do that in Manchester until the Euroimmune patented it fully, so we can't do that anymore. And when it comes to sensitivity and specificity, it took some time for us to understand these parameters. So back in 2014, this is a meta-analysis of 15 studies, 2,200 patients, and they found the sensitivity in about 2/3 of the patients. You find that the PMN is associated with the condition, with the antibody. But the specificity, it is one of the very high affinity antibody. Even more higher affinity, according to my professor, he's a renal immunologist, he thinks that he showed that actually this is much more avid antibody compared to GBM antibody, which we know is extremely specific. So there is extreme specificity, very high specificity of nearly 95%. To the point that there were subsequent studies, this was published from 2018, so now 5-6 years ago, where the Mayo group found that actually if there are set parameters that you could consider your patients with nephrotic syndrome and you look at their clinical parameters, there is a potential that actually if they meet certain criteria, you could probably get away not needing actually a kidney biopsy. When was the time when we thought that we could define or diagnose a kidney condition without a kidney or glomerular condition without a kidney biopsy? So it's a huge leap in our understanding, and I suspect still many people have a pinch of salt when they consider this as a possible thing that they could offer to the patients, but practice is changing. So this is from our own center. When we studied about 180 patients, we can see the variation in the antibody titer in the left column with the levels of anti-PLA2R in primary, secondary, and other diseases, other as in non-MN glomerular diseases. And the specificity, the area under the curve is really good. And I don't know if you can see the numbers there, but in our study we find a sensitivity of around 75% and specificity of 97.9%. And the sensitivity and specificity, you can sacrifice sensitivity to gain more specificity or the other way around if you increase the threshold of the antibody titer. And in our study we found that if you reach a threshold of more than 40, the specificity is actually nearly 1. Almost everybody who has an antibody titer over 40 units per mil, they are bound to have, these are biopsy, these are tested against biopsy proven diagnosis. But of course, if you lose the sensitivity, so the sensitivity is only 70%. Compare that to move the sensitivity to only 10 units per mil, and then you lose the specificity. So it depends on your index of suspicion about alternative diagnosis when you could use different thresholds. This is some unpublished study which is currently being worked through an NIHR grant. Hopefully we'll be able to submit in the next month or two. So here we show, this is a meta-analysis of 35 studies. So in 2014 I showed you the 15 studies. Now we moved on. In the last 10 years we had more studies that have come through, and each dot, the column on the dot, or the color of the dot, suggests a threshold. And you could see that there is a fishnet appearance there where you can see that the different thresholds actually could potentially meet the sensitivity and specificity. That is for ELISA. Now if you ask for a Euroimmune ELISA test, they give Euroimmune ELISA, but of course there is another Euroimmune test for PLA2R antibody, which is the immunofluorescence test. It is a lot more sensitive, but it is very subjective. So a threshold of 1 in 10 dilution is generally used as a positive finding, and those you could see at the threshold of 1 in 10, the specificity is pretty good. And this probably first time that has been done in a meta-analysis where we looked at different, in all of the published studies, 55 different thresholds across the papers, and these are the different sensitivities and specificities. Why is it important? It is important because you want to know if, would you consider doing a biopsy for your patient if you have a classic patient with nephrotic syndrome, you don't see any other cause, and their PLA2R antibody is positive. Do you biopsy the patient? Can I have a show of hands? How many would biopsy such a patient? If their PLA2R antibody positive and their classic nephrotic syndrome, you don't suspect any secondary cause? Biopsy, 1? No? Change of practice already. Excellent. So I don't need to convince you. But if you were to argue potential savings, or for the patients or for the service, whichever way you look at it, for 1,000 patients with a classic nephrotic syndrome, you could potentially exclude 160 patients, save 160 patients from biopsying, at the expense of 2 patients potentially having non-MN related diagnosis. So you could argue whether you would want to take that, or you want to be absolutely 100% proof, need that 100% proof. The next little segment is around the genetic association. Now, I think earlier somebody asked about the CKM syndrome, and Dr. Sharma was talking about the genetic association. There is a different storyline here, certainly. There is single nucleotide polymorphisms. These are very cumbersome tests. These are not done in routine laboratories, etc. But nonetheless, to prove that there is a genetic association, you could see that there are associations with HLA haplotype as well as the PLA2R single nucleotide polymorphisms, and the risk varies as you go from the GGGG genotype to AAAA genotype. The risk increases from, compared to them, it's about 78 times more riskier having this cohort. But how common is that? That's a different question. We'll come to that in a second. And not only that having the PLA2R and the high-risk HLA genotype is at risk of people having membranous nephropathy, but also actually the T-test, antibody T-test. So the left one shows the proportion of patients with PLA2R antibodies, and the relative risk, again, as you could see, from the lowest risk genotype to the highest risk genotype. The previous study showed about 78 here. This is a UK Biobank study of 500,000 normal population, 500,000 population, and the risk with this genotype, with the high risk genotype, is about 30 times. And what we also showed some years ago, this is now probably 10 years old now, is not just a genotype, but actually you do serotype, almost like HLA serotype for transplant in the transplant labs that we do to facilitate transplant listing or matching, etc. But this is a next level serotyping where you don't do just A1 or A52 or DQ, etc. But you go to the next level, so you have a DQ A1, O5, O1. This is a large proportion is of course Caucasian, being a UK study. But you could see that as the number of alleles increases, the titer level of the antibody increases, both with DQA1, O5, O1 and DQB1, O2, O1. And we find this is a study of 12 patients where we did immunoadsorption study as a potential treatment for removal of antibodies alone without any other immunosuppressive treatment. And you see that actually as the DQ alleles are higher, the having at least one DQ A0501 gives rise to that high level of antibodies compared to not having either of the allele being DQA501. So there is a wide range in the potency of the way how the antigen is presented that the cells make these antibodies, which is a fascinating phenomenon. There's more to be understood, of course. Sorry, I see the time is up. Couple of minutes. Thank you. Thank you. So I'll probably wrap this quickly. So PLA2R, why is it important? A, in diagnosis we said. B, does it help in prognostication? You have a patient with high PLA2Rs, low PLA2Rs. What does that mean? So early studies from 2010 and 2014 showed that there is increased relevance to spontaneous remission, doubling of serum creatinine, increased risk of relapses, etc. But then subsequent studies, when you factor the baseline and correct for baseline proteinuria and GFR test, actually PLA2R doesn't have any more association. I'll probably move to the last stage. So these are the individual PLA2R positive versus high titer versus low titer, survival probability, as well as the cumulative risk of partial remission. You could see that they mirror. And there are a few other studies which have shown, the Dutch group has shown very similar ones. Yeah, thank you, sir. I'll just probably finish at the last slide, which is just a conclusion, and you can have a quick read. Thank you.
Dr. Anil, that was a wonderful talk. I think I saw your paper in 2013 when, from University of Manchester, when you first came up with the anti-PLA2 receptor antibodies. So
yes, sir.
It's nice that you came all the way from there for giving this talk, very lucid talk. So any quick questions?
Sir, thank you for that lucid talk, sir. I just have one question. In primary membranous nephropathy, if you are not doing a biopsy and you are following the patient with anti-PLA2R levels, how frequently you do that? If you don't do biopsy at the initial point, will you consider doing biopsy at some point in the course of the disease? And if yes, what are the predictors for that?
Yeah, very good question, sir. Irrespective of whether you do biopsy or not, in terms of monitoring, what we do is at least every 2 to 3 month monitoring if we were observing the patients. If we were treating the patients, we monitor even more frequently, about once a month. Especially we use our intravenous cyclophosphamide rather than oral cyclophosphamide, and we use monthly intravenous cyclophosphamide because that allows us less dosage cumulatively to use, and we do monthly monitoring. Almost always, we find that PLA2R antibodies get completely 90% depleted by 2 months of treatment. But of course, if you don't treat the patient and if you're following during an observational period, because the GFR is well preserved and the patient is not too symptomatic, once every 2 to 3 months should be sufficient, and that's what the KDIGO suggests.
Okay, we'll conclude this session. Thank you very much, Anil.
Thank you, sir. Thank you all.